Sir, we'll start, sir. Hello, sir.
Am I audible?
Yes, sir. Yes, sir.
Okay. Today we'll discuss about cerebral venous thrombosis. Okay. Just move the slides. All of you know the terminologies like cerebral venous thrombosis, cortical venous thrombosis, dural venous thrombosis. All are different. The definition of cerebral venous thrombosis, as we all mentioned CVT, this cerebral venous thrombosis. It is the thrombosis involvement of the dural venous cyanosis and or cortical veins, either of the involvement of these called, the broad term is cerebral venous thrombosis. You can write as like thrombosis of the dural venous sinuses or cortical vein sinus thrombosis. So while writing the diagnosis, do mention the which are the venous systems involved. Or cortical veins are like vena trabbe, vena labbe, all those things are there. Those are all cortical veins. And dural sinus venuses, sagittal, transverse, straight sinuses, all those are dural venous sinuses. So while writing diagnosis, you mention what are the veins involved. Okay, next slide. Most commonly occurs in a female. 3 out of the 4 female patient would be females. Age group would be between 20 to 50 years. Nowadays, the incidence of risk factors and proper evaluation by venogram techniques, the incidence of CVT is increased. Okay. And first case was published in 1825 in France. The patient was presented with severe headache and epilepsy due to the thrombosis of superior sagittal sinus and lateral sinuses. Next slide. Incidence, the sagittal superior sinus, it carries around 62% of total cortical vein thrombosis, and the least common would be cavernous sinus. It carries around 1%. Okay, 50 to 60% of the patient will come with more than one sinus involvement, as all of you know, and as all of you seen prior. And most common presentation would be subacute onset.
Hello, sir. Sir, you're not audible.
Forward, just move the slides. Next slide, please. Okay, etiology, as all of you know, multiple n number of causes will be there. Most common cause you might be knowing. So whenever a patient presented with complaints of headache, focal deficit, evaluated, found to have cortical vein thrombosis, you need to rule out these causes also. So other rarer causes I'm telling, even iron deficiency anemia can also cause cortical vein thrombosis. Can anybody explain why it causes? Any clue? Can anybody comment? Have you seen any patient, those who presented with cortical vein thrombosis, having severe iron deficiency anemia?
Abhishek. Sir, here. Yeah, tell me. I asked question in the morning. What happens when iron deficiency anemia?
Sir.
Okay. In iron deficiency anemia, there will be reactive thrombocytosis that will activate the hypercoagulable status. So always in a case of CVT, you should see for iron deficiency anemia. Okay. Other rare causes would be inflammatory bowel diseases, hypo or hyperthyroidism, ENT infections, post-surgery, lumbar punctures do also causes these kind of cerebral venous thrombosis. This is secondary to spontaneous intracranial hypotension that will drag the cerebral parenchyma downwards, that will obstruct the cortical venous flow. So that will causes cortical vein thrombosis. Rare, it is mentioned as 1.9%. Head trauma and drugs like lithium, vitamin A, and IV immunoglobulin. And you need to see for vascular abnormalities. Dural AV fistulas also causes cortical vein thrombosis due to the flow abnormalities. Okay, these are all the rarer causes. Other causes you look into it. Okay, later after the class. Next slide. So pathophysiology mainly due to the obstruction of the venous sinuses that will indirectly increases the capillary venous pressure. So it will leads to a decrease in the cerebral blood flow that leads to the ischemic damage to the neurons that will causes the cytotoxic edema. If pressure go on increases, that will lead to capillary rupture, sometimes lead to the parenchymal hemorrhages. So it leads to the damage of the blood-brain barrier. Finally, ultimately land up in the vasogenic edema. All these factors will lead to the increase in the intracranial pressure due to the impairment of CSF absorption. These are the main pathophysiology in case of cortical vein thrombosis. So you need to address the thrombosis as early as possible. If you make a treatment or diagnosis late, it will lead to all these kind of complications. Okay. Next slide. So when to suspect? So if a patient come to the emergency with a history of headache, that is secondary headache, and features of raised intracranial pressure like papilledema, bilateral lateral rectal palsy, focal neurological deficit, altered consciousness, seizures, with background history of oral contraceptive intake, postpartum, puerperium, pregnancy, malignancy, or iron deficiency anemia, you need to rule out cortical vein thrombosis. Okay. Next slide. So clinical features, most of the clinical features will be according to the site of involvement. Like if, say for example, if sigmoid sinus involves, it will lead to lower cranial nerve palsies. If deep venous system like basal ganglia or internal capsule region, deep venous sinus system affected, patient will come to the emergency with a diffuse encephalopathy. If only cortical small branches cortical veins will causes focal deficits and seizures. If cavernous sinus involves, it will lead to the ocular nerve palsies, fourth nerve, sixth nerve, with the headache, chemosis, proptosis. Next slide. If transverse sinus involves, it will lead to the pyramidal symptoms, and sometimes if extends into the jugular vein, it will lead to the lower cranial nerve palsies also. And if involvement of the superior sagittal sinus, it will lead to the raised ICT features, focal deficits, cranial nerve palsies, aphasias, hemianopias, and hemisensory loss due to the involvement of cortex. Next slide. So investigation, basic investigation, we should get it in all the patients is complete hemogram and including our platelet and MCV, MCH, hemoglobin level, prothrombin time, and APTT also. These are the basic investigation. Other causes, next slide. Sometimes D-dimer will also help. It is a sensitive marker, but it do not exclude the diagnosis. And lumbar puncture rarely indicated because some of the pyogenic meningitis and tubercular meningitis do also causes cortical vein thrombosis. So if you have clinical suspicion of meningoencephalitis with CVT, you need to rule out these kind of bacterial infection, because treatment would be according to the etiological agent. Not only treating only with the anticoagulants, you need to treat underlying infections also. Rest of the investigation according to the suspected etiology. As I told in the earlier part, the etiology chart, you just go through that chart and see accordingly and investigate accordingly. Next slide.
हाँ, audible, sir.
Okay. Radiological investigations. First and foremost important is normal CT brain, because in most of our government hospital, MRI would not be available, MR venography would not be available, sometime contrast would not be available. So you should see detail regarding the NCCT findings of the cortical vein thrombosis. Other investigations include distal subtraction angiography, and sometimes direct cerebral venography could also be done. So you should be knowing about NCCT head findings in case of cortical vein thrombosis. We'll go through the radiological findings in detail. Okay, next slide. Okay, direct signs and indirect signs. So whenever you see the CT, you look for the sinus, dural venous sinuses. If any hyperintense signal, hyperdense signal is there, that is called dense card sign. So involvement of the dural venous sinuses, it will leads to the hyperdense signals like dense card sign, dense lateral sinus, dense jugular vein sign, and dense triangle sign. I will show these pictures in the next slides. And other subtle signs you should see for hemorrhagic infarct, multifocal hemorrhages, subdural hemorrhages, subarachnoid hemorrhages, slit-like ventricles, and diffuse cerebral edema. These also associated findings will be there in case of cortical venous thrombosis in a normal CT. Okay, next slide. So this is the dense card sign. So this is a card-like structure that is prominently visible on the normal CT brain. Involvement of the sagittal sinuses and some superficial veins are also there. This is called dense card sign. If it involves the sagittal, it can involve the any part of the dural sinus. If it is involved the sagittal, this is called sagittal region, dense card sign. If it involves the transverse cards, jugular, all those things can also be seen. Okay, next slide. This is the left transverse sinus, dural sinuses. Here also some dense structure is visible on the normal CT. This is also called card sign, predominantly involving the left transverse sinus, and some hematoma is there in the temporal lobe. And venography is also showing the left transverse sinus thrombosis. Next slide. And as all of you know, dense triangle sign or dense clot sign, normal CT in a superior sagittal sinus, as you know, in the posterior aspect, you are seeing the hyperdense signal. So this is called dense clot sign or dense triangle sign. It is seen in around 30 to 35% of the patients. Next slide. This is also one more dense sign that is involving the sigmoid sinus. Next slide. This is also one of the dense sign that is involving the posterior aspect of the straight sinus, and bilateral occipital hemorrhagic infarcts are also visible here. So you need to see for cerebral edema. Here in pictures, cerebral edema is there, and slit-like ventricles also there. Hemorrhagic infarcts are also there, and dense card sign is also there. So these are the subtle signs you need to see in the emergency whenever you are having only plain CT brain. Okay, next slide. Here also one more dense sign that is involving the left transverse sinus, and some hemorrhagic conversion is also there in the temporal lobe. Next slide. So come to the next slide, the post contrast CT scan findings. After giving the contrast, you can see the other findings like empty delta sign and opacification of the dural sinuses, and other indirect signs like focal enhancement or gyral enhancement, and sometimes it do looks like space occupying lesion due to the hemorrhagic conversion and mass effect. Sometimes it may misreport as space occupying intracranial space occupying lesions, and sometimes due to the extravasation of the blood, that will causes these dural sinuses or tentorial enhancement. These are also subtle signs you need to look for these kind. Okay, next slide. So come to the empty delta sign. Most of the people might have seen, is seen in around 10 to 30% of the patients. It was the first sign described and the contrast CT. This is the triangular area of enhancement with relatively low attenuating center. This is due to the thrombosed sinus, likely due to the enhancement of rich dural venous collateral circulation surrounding the thrombosed sinus, producing the central region low attenuation. Next slide. This is the most common sign. This is the diagram. This is the table showing the percentage of these signs in a cortical venous thrombosis. First most common sign would be empty delta sign, followed by dense vein sign, then compressed ventricles, then hemorrhages, followed by card signs. Okay, these are the common signs you notice in the cortical venous sinus thrombosis. Okay, next slide. In early thrombosis, the empty delta sign may be absent. In that scenario, we need to see per the complete venogram in the CECT setting. Okay, because only 30% of the patient will be having empty delta sign. So if empty delta sign is not there, not means patient not having CVT. So you should look for the venous tree also. Okay, in a chronic stage also, this empty delta sign will disappear due to the recannulation of the thrombus after the treatment. Okay, next slide. This is CCT brain. You are seeing the posterior in the somewhere you can mark it in the posterior aspect of the sagittal sinus. You are seeing small hypodense lesion, like hypotension opacity is there. So this is called empty delta sign. Okay, or empty triangle sign, because due to the lack of flow of the blood through the dural sinus, this is called empty delta sign. Is seen in 30% of the cortical venous sinus thrombosis patients. Okay, next slide. CT venography is effective tool in the evaluation of the venous anatomy. It has high sensitivity compared to DSA, but it is superior to the MR venogram. Compared to the MR venograms, if CT venogram is there, if patient not having any risk factors, you can get CT venogram to diagnose the CVT. Next slide. Because drawback is it will take too much time, because whenever you do the venogram, you need to see for the arterial tree. Then after that, the technician should technician should be trained enough to separate the arterial and venous tree, and he should make the various phases of the venous system. So it is operator dependent. So if the trained technician is there, CT venogram is the best modality. If the trained technician is not there, means that would be the major disadvantage to diagnose the CT venogram, because the reconstruction of venous space would be difficult in a CT machine in an untrained person. Okay, next slide. This is the post contrast CT. You are seeing the bleeding, and the dural venous sinuses is superior sagittal, and the mid part also it is not visible, and straight sinus also lack of flow is there. Next slide. In most of the time, I will be seeing the transverse venous sinus stenosis. Sometimes it will sometime after improper reporting, sometimes they will report as cortical vena thrombosis also. So in a transverse venous stenosis or transverse sinus stenosis, patient will be having these kind of pictures since birth only. You can do the CT scan, you can see for the bony canal or bony impression on the CT. If it is since birth, the bony canal or the bony impression will be small as compared to new onset cortical venous thrombosis. And in case of transverse sinus stenosis, the gradual tapering of the sinuses will be there. But in case of thrombosis, patient will venogram will show sudden cut off of dural sinuses. These are the two differential features will help to differentiate the transverse venous stenosis versus transverse venous sinus thrombosis. Any doubt in this? This is very important. Most of the clinical settings you might be seeing transverse venous stenosis versus the venous thrombosis involving the transverse venous sinuses. Any doubt?
No, sir.
Okay, next slide. Then come to the CVT venogram. The MRI also very helpful in the diagnosis of cortical venous thrombosis. The most important sequence would be T2 sequence. Okay, you should be knowing this T2 sequences in the cortical venous thrombosis. Okay, I will tell you the concept of flow wide in the next slide. Okay, can you change it? Okay, flow wides, these are the terms which are used to describe the MRI studies, and it refers to the signal loss occurring within the moving fluid. Usually CSO, when the fluid is moving at the sufficient velocity relative to MRI apparatus. Say for an example, if the fluid is moving so fastly so that MRI signals cannot able to pick up, that will leads to normally hypodense signal. So this is called flow wides. Normal flow wides will be black color because it will not pick up, because blood is whenever blood is flowing, the MRI will not able to pick up the flow of signal that leads to the signal loss, that will lead to the hypodense signal. If in case any obstruction, that will increases the flow of the blood, that will lead to the lack of signal void. This is called lack of signal. Normally, you can next slide. Samir, put next slide. Next one. You see, in this normally, in the right side, this hypodense signal is there. Opposite. This is the normal signal density. Whenever the CSF is flowing or blood is flowing, MRI will not pick up properly. So the velocity of flowing blood, if it is more, that time it will leads to the lack of signal. This is the normal flow wide. Okay, normal flow wide will not be picked up in a normal person. If in case of any obstruction, opposite side, the flow wide will be lost, because this due to the obstruction, this is what we are seeing. This is a thrombus that is obstructing the flow, that will leads to the lack of flow wide. This is a lack of flow wide is the characteristic of cortical venous thrombosis. So one sequence, if you want to diagnose the cortical venous thrombosis, you take the T2 MRI images and see for the flow wides. If lack of flow wide are there, it indirectly indicates the cortical venous thrombosis. Okay, in a MRI, if you want to diagnose the CVT, you see the lack of flow wide in the T2 sequences. Okay, go back to the slides. Any confusion regarding this? Because most commonly, sometimes they will bring the MRI without reporting also. Some MRI plain film also they will bring to the emergency. That time, you need to see for these findings. So it will help you to diagnose early, and you can treat the patient as early as possible. Okay. Any doubt in flow wide concept?
No, sir.
No. Okay. Okay. In cortical vein thrombosis, MRI findings, like one is I told earlier, lack of flow wide, and second one is that intraluminal clot will appears as an abnormal signal. And in contrast, again, you can see the empty delta sign as in your CT scan also. Okay. And indirect sign, due to the blockage of the thrombus, it will lead to the collateral formation. This can be seen on the venogram. And sometimes you can see emissary veins due to the obstruction, that will lead to proximal increase in the pressure of the venous tree. And other signs you can see cerebral venous infarction, intracerebral hemorrhage, and other features of raised ICT like diffuse cerebral edema, slit-like ventricles. All those things can also be seen in MRI also. Next slide. Okay, this is the hypodense signal in the posterior aspect of the T1 sequences. Okay, and this one is the JRE or susceptibility weighted image. Some hemorrhagic conversion also there. And here also you can see the flow wide in the image B. Flow wide is there. And then MR venogram, last picture, you can see the obstruction in the straight sinuses. So you can, in the JRE images, you can see the hemorrhage. In T2, you can see the flow wide, and venogram, there will be clear cut, sudden cut up of the venous tree. These are all the findings to identify the cortical vein thrombosis in MRI. Next slide. And one more, this is the MRI. This is the T1 and T2. In a plain MRI, you can see the dense card sign. As you see in the CT scan, you can see dense card sign in MRI also. This is the transverse sinus involving the cortical thrombosis involving the right transverse sinuses in T1 and in T2. Okay. Next slide. Let us come to the contrast MRI. Here you can see some meningeal thickening signs or meningeal enhancement sign, tentorial enhancements, and dense triangle sign also you can see, as you have seen in the CT scan. Next slide. You can see this is the superior sagittal aspect. In the mid part, hypodense signal is there. That is due to the lack of flow of blood in the cortical venous sinuses. That will lead to the abnormal enhancement. And in confluent sinuses, you are seeing the empty delta sign. Here also, flow is not proper, so that will be picked up by your contrast. And in one more MRI, this side, you are seeing the left transverse sinus thrombosis. This is the hypodense signal is your thrombus. So thrombus will appear as hypodense signal in the MRI contrast. Next slide. Again, abnormal enhancement will be there due to the extravasation of the blood from the dural sinuses. And you can see here also some filling defect in the superior sagittal sinus. This black color hypotenuse signal is there. No, this is filling defect due to the thrombus that is causing the obstruction of the blood flow. Next slide. Again, one more. This is empty delta sign. You can see the flow defect in the posterior aspect of the sagittal sinuses. Next, in deep vein thrombosis, due to the involvement of these basal ganglia, patient can present with acute onset encephalopathy. So you need to see the vasogenic edema and cytotoxic edema in subcortical structure along with the empty delta sign. Here also flow wide difficulty is there, and hyperintense signal predominantly seen in the thalamus and basal ganglia area. This is due to the obstruction of the deep dural venous sinuses. Next slide. Here you are seeing the hyperintense signal changes in the straight sinuses and vein of Galen. These are all the vein of Galen usually drains the subcortical structure and deep venous sinuses, deep brain structures. So any obstruction that will lead to the hyperintense signal in the venous sinuses. So patient can present with the diffuse encephalopathy. Next slide. So some MR venogram is also helpful in the diagnosis of cortical venous thrombosis, but it is not superior than the CT venogram. Without using contrast also, we can do the MR venogram, that is called 2-dimensional or 3-dimensional time of flight images we can use, and we can diagnose the cortical vein thrombosis. Hallmark of thrombosis is absence of signal on the venous tree. Okay, next slide. This is a venous tree. Again, you are seeing here the complete non-visualization of the right transverse sinuses. Okay. So here you are seeing whenever stenosis is there, there will be gradual tapering of the venous system will be there. Here sudden cutoff of transverse sinus is there. Okay. This will help you to differentiate between transverse venous sinus stenosis versus thrombosis. Next
If
slide.
Ganesh,
Sir.
if there is a hypoplastic, how will you look at?
Sir, if it is hypoplastic, almost hypoplastic are associated with stenosis only, sir. Hypoplastic and stenotic findings will be seen. It better can be confirmed by CT scan. In CT scan, if hypoplasia or stenosis is there, the bony canal which is present since birth will be small, sir. And venous foramina, that the venous foramina draining areas will also be small. That foramina through venous sinuses are draining, that also small, sir.
That's okay.
CT bone you can make out, sir. That is a very good modality actually. If you are having any doubt regarding hypoplastic versus thrombosis, you can do CT, see for the bony canal and that bony groove through which the venous sinus is going. So if it is small, you can label it as hypoplastic.
Okay.
Okay.
Thank you.
Next slide. Okay, sometime due to the backflow obstruction, there will be cytotoxicity that will lead to death of the neuron, that will lead to the cytotoxic edema and vasogenic edema. It can be picked up by MRI. By seeing diffusion weighted ADC and flare images, you can make out patient whether he is having cytotoxic edema or vasogenic edema. We'll plan for MRI or CT classes one day. That would be better for you. So identify the cytotoxic and vasogenic edema. Again, that is the big topic. We'll discuss in one more class. Okay, regarding cytotoxic and vasogenic edema, DWR ADC sequences in the stroke. Okay, next slide. Sometimes due to the venous obstruction, that will lead to the thrombosis. Predominantly thrombosis will be involved in the superior sagittal, straight sinus and internal cerebral vein. That will lead to the venous infarct. As like your arterial infarct, venous infarct will also occur. Most commonly bilateral. Due to the venous infarct, finally it will lead to the hemorrhagic conversion. That is called hemorrhagic conversion of the venous infarct, predominantly seen on the superior sagittal sinuses, straight sinuses and internal cerebral vein. So if patient is having hemorrhagic infarct, you need to rule out cortical venous thrombosis if been present in a non-arterial territory. Okay, next slide. Again, this is the cytotoxic and vasogenic edema. We'll discuss separate class. It would be better rather than usually in cytotoxic edema, diffusion restriction will be there, ADC will be less. In vasogenic edema, diffusion restriction will not be there, but ADC values will be more and flare hyperintense signals will be there in case of vasogenic edema. Next slide. Okay, next slide. Okay, let us come to the treatment. First and foremost important is airway breathing circulation. You need to see, because cortical venous thrombosis patient will present most commonly subacutely present. They will have features of the raised ICT, seizures, and poor GCS. So first you triage the patient, you do the airway breathing circulation, and see for any abnormal signs of the herniations. So treat the underlying cause, control the seizures if patient is having. Don't give empirical anti-epileptic drug. If patient is having raised ICT, we need to address the raised ICT by giving mannitol or other anti-edema measure, ventilation if needed, and antithrombotic therapy. Okay. Next slide. So as all of you know, and the stroke other scores, you might be knowing that NIHS, ABCD2, MRS, aspect, CT volume score, ICS score, and for CVT also one prognostic score is there. You should always apply. So whenever you are writing a case paper of CVT, kindly write this prognostic score for CVT, because you can assess the patient. A patient is having more severe score, you need to be aggressive in the treatment. So for malignancy, they have given, if patient is having malignancy, give 2 points. If patient is comatose, 2 points. If patient is having deep venous thrombosis, give 2 points. If altered mental status is there 1, and intracranial hemorrhage is there 1. Total points would be around 9. If patient is having 3 or less than 3, will have good outcome. And if the score is more than 3 or equal to 3, will have high risk, and they will end up with the complication. Okay. Any doubt in this score? So all CVT patient you should write. Okay. Whatever the stroke I have told, stroke score I have told prior, you should mention all this score also. Sandeep sir, kindly check it. Okay. Next slide.
Okay, Ganesh sir, check ಮಾಡ್ತೀನಿ.
Okay, you received the patient, you did the detailed examination, you got the imaging done, and CVT is confirmed. You do the score system. If patient is having 3 or less than 3 score of CVT prognostic score, so you can directly start with anticoagulation, and patient will be on the safer zone. If patient is having score of 3 or more than 3, so multidisciplinary action should be there, because patient will may land up with the complications like midline shift and herniation and PCA territory hypodensity. What is the importance of PCA territory hypodensity in a setting of CVT or any raised ICT? Anybody tell? What does it indicate? PCA territory hypodensity in a setting of raised ICT patient. Anybody? Okay. In a case of raised ICT, due to the midline shift, if herniation start occurring, that will causes the vertebral artery compression. That will leads to the early early PCA territory infarct or PCA hypodensity. So if a patient having raised ICT feature, kindly look for these PCA territory hypodensities and midbrain surrounding cisternal areas, and pupillary involvement, opposite corticospinal tract involvement, dip in the GCS score. These are all the indirect signs that patient is herniating. If you don't treat, if you don't address during that time, patient will land up in the complication. Like once brainstem reflexes gone, you cannot able to do anything. Okay, CVT is one of the best treatable condition compared to other strokes. Okay, so always look for the raised ICT features or any herniation signs. You discuss with the neurosurgeon or intervention neurologist for the next treatment. So if patient is having all these signs, you refer or you take a call for neurosurgery for decompressive hemicraniectomy. Endovascular treatment is not yet approved. Some of the centers they are doing. We'll see regarding that in the next slides. Okay. Any doubt regarding this management of CVT? Most commonly you are seeing CVT patients. Any doubt in this slide or any doubt in management of the CVT? Can we go ahead?
Yes, sir.
Sir.
Okay. Next slide. Next, most common question would be how many days we should give heparin. So after hospitalization, initial days you need to give injectable heparin derivatives like low molecular heparin or unfractionated heparin. Ideally would be 5 to 7 days as book says, because the time is needed to obtain an adequate and persistent reduction in the vitamin K dependent clotting factors with the oral anticoagulants like warfarin. So minimum time would be around 5 to 7 days. For newer oral anticoagulants, some I think 2 to 3 studies are going on. No definite guidelines for the novel oral anticoagulants, but benefit is there. How many days we have to give heparin in a setting of Novax drugs? Okay. For other drugs like warfarin, acetram, you can give 5 to 7 days. These drugs, some says you can directly start with novel oral anticoagulants because the effects will start soon. And some says some guidelines are not yet come, so better to give the heparin for 5 days, then you shift to the novel oral anticoagulant drugs. So how many duration of the anticoagulant? If a patient having a CVT and diagnosed to have a transient risk factor like ENT site infections, trauma, head injury, or any dehydration, in this setting, these are the transient risk factor. In this setting, you can give only up to 3 to 6 months and you can stop it. In a case of unknown cause, even after extensive evaluation, you are not able to find out the cause for CVT, that setting you can give up to 12 months, 6 to 12 months. And third scenario would be if a patient having cortical vein thrombosis more than 2 episode and 1 episode more 2 or more than episode of CVT or 1 episode with severe prothrombotic condition. In these condition, we need to give anticoagulants lifelong. Okay, I repeat once again, if a transient risk factors are there like sinusitis, surgical site infection, post-surgery, trauma, in that setting only you can give 3 to 6 months. If you don't able to get 6 to 12 months, 2 or more episodes of CVT, if no causes, that time patient is having more recurrent CVT, 2 or more than recurrent CVT, that time also you should give lifelong anticoagulation. If patient is having severe prothrombic condition, that is hypercoagulable status, you need to give lifelong. Okay, any doubt in this slide? This is the most common doubt we face during our PG days. Any doubts in this slide?
After 2 months, the patient comes and in the repeat MRI, there is no clot, sir. Everything has resolved and reperfusion is there. Sir. Do we still continue or do we stop the
cause for this?
causes, sir?
Cause for CVT.
We have to find it.
Here the duration would be according to the cause. Okay.
Yes.
Tell me.
Sir, like we had cases of pregnant ladies that come. So in that we assume the cause to be because of dehydration or like that, sir. So
Okay.
is that enough to decide, sir, the duration of this one, or you have to go more
Usually
for
in
the...
pregnancy, they says 50% of the patient will have other causes. A dictum is there if a pregnant woman comes, not always means dehydration and hormonal changes that are leading to CVT. You need to rule out other causes also. Most of 50% of the patient will have other causes. Okay. You try to find out other causes also. If you don't get the cause, you can treat as transient risk factor, like 3 to 6 months you can treat, and then you stop the anticoagulant. Clear or still you are having doubt? If you are having doubt, ask me, no problem.
Clear.
Clear? First, you try to identify the cause. Causes would be transient, or it can be idiopathic, or it can be permanent, like lifelong, this prothrombotic condition. In prothrombotic condition, no way you need to give. If patient is having 2 or more than recurrent episode, if you're not getting cause, that time also you need to give lifelong. If even after extensive evaluation, you don't get the cause, only 1 episode of CVT is there, you give for 6 to 12 months. Only transient risk factor is there, that was the first and last episode, give for 3 to 6 months and stop. Okay. If the patient is improving clinically, no need to get re-imaging done. Okay. Next slide. Okay, initial anticoagulation can be your IV heparin, it can be your low molecular heparin or unfractionated heparin, and you should always see for the dose. Okay, if a patient is coming to CVT around 40 kg, you need to give 40 units, or if patient is having 60 kg, you need to give 60 milligram. That is, I think 0.4 ml contains 40 milligram, 0.6 ml contains 60 milligram. These are all the preparations. So you should always check the weight, because if you give the inadequate dose, again patient will land up with the complaint of cortical vein thrombosis. Always, most of the time we will write 0.6 ml BD for all the patient. Don't do like that. Okay, in PG days we also did. So check the body weight and give accordingly. Okay, if patient is having overweight, like more than 100 kg is there, just calculate the ideal body weight. That is, ideal body weight calculator is there. You Google it, ideal body weight calculator will come. You apply that ideal body weight calculator and you will get the weight. According to that, you give 1 milligram per kg. So it's the adequate dose should be given. Okay, next slide. Then next would be choice, timing and duration. Choice nowadays, like most this is the respect CVT trial and action CVT trial. These are the two trials concluded that novel oral anticoagulant, that is your dabigatran, apixaban, rivaroxaban, all these newer oral anticoagulants can also be used in a cortical venous thrombosis, and it has equal efficacy as compared to older drug, that is warfarin, with less risk of bleeding. So in a case of CVT, you can give newer oral anticoagulant. Okay, for exact duration of anticoagulation, one more trial is going on, XCOVA CVT trial. I think by end of December, the results will come for this trial. Okay, till that you can use this 3 to 6 months, 6 to 12 months, and lifelong therapy according to the causative agents. Any doubt in this slide? These are the slides taken from the latest conference. I think last 3 months ago, stroke conference was there in Hubli. Okay, that time I took some picture. That one only I have just copied here. Any doubt in this? In your hospital, like which drugs you are using? Warfarin, acetram, or direct oral anticoagulants? Sandeep sir.
ನಾವು ಇಲ್ಲಿ
Yes.
ನಾನು ಇಲ್ಲಿ ನಮ್ಮಲ್ಲಿ ಅಂತೂ ವಾರ್ಫರಿನ್ ಯೂಸ್ ಮಾಡ್ತೀನಿ ಗೌರ್ಮೆಂಟ್ ಒಳಗ
Yes, sir.
ವಾರ್ಫರ್ ಯೂಸ್ ಮಾಡ್ತೀವಿ. ಹೊರಗಡೆ ನಾನು ಯೂಸ್ ಮಾಡೋದಾತಂದ್ರೆ ಭಾಳ ಏಜ್ ಮೇಲೆ ಹೋಗ್ತೀನಿ.
Okay, sir.
ಏಜ್ ಸಿರಮ್ ಕ್ರಿಯಾಟಿನಿನ್ ಮೇಲೆ ನೋಡ್ಕೊಂತೀನಿ. ಇಫ್
Okay, sir.
ಇದಿತ್ತಂದ್ರೆ ನಾನು ಗೋ ವಿತ್ DVT ಇತ್ತಂದ್ರೆ ಗೋ ವಿತ್ ರಿವರಾಕ್ಸಬಾನ್ ಅಂದ್ರ 15 mg BD ಫಾರ್ 21 days ಕೊಟ್ಟ 20 mg OD ಫಾರ್ 3 months to 6 months. After that I will see ಮತ್ತೆ ಏನಾರ ಇರ್ಬೇಕು.
For CVT patient also you are using, no, sir? For CVT
CVT
patient also you are using that.
CVT
Okay, because these trials have shown very good results, sir, and less bleeding risk as compared to warfarin. So action CVT and the respect trial. Recent is the action CVT trial, which is published in 2022 Stroke Journal. So you can use any oral direct anticoagulation for the treatment of cortical vein thrombosis. Because problem with the warfarin is like, again we have to monitor the INR frequently. We have to the patient, and if compliance is not good, if INR is again less, again patient will have chances of getting cortical vein thrombosis only, and bleeding risk could be more in warfarin acetram as compared to dabigatran, and cost factor would be the major deciding factors in our comment.
The patients also withheld very good. They also, some people don't want that repeated of coming to hospital and checking INR everything.
Yes, sir.
These things, that is also, they are very much compatible for Novak.
Novax.
So.
Okay, sir. Next slide. Okay, this is the action CVT trial. They included the patient of cortical vein thrombosis, around 1025 patients, and they randomized the patient case and control and given the direct oral anticoagulants and warfarin. And the final results was like a similar recurrent venous thrombosis in both group, and similar death group in the both similar death rate in the both group, but lower major hemorrhagic risk with the direct oral anticoagulants. And they concluded that the direct oral anticoagulants can also be used in cortical vein thrombosis. Okay, this is a recent study. Okay, action CVT trial. You remember this name? Okay, next slide. In a case of intracranial raised hypertension in a cortical venous cyanosis thrombosis setting, general recommendation you all might be knowing, like elevation of the head end, ICU, mild sedation, asthmatic therapy with the mannitol or hypertonic saline, hyperventilation, and ICP monitoring. These are the common things. And the other things that we can do are therapeutic lumbar puncture. It is not indicated in all the patient. If patient is having threatening vision loss, in that case we can do safely. And acetazolamide and diuretics also not proven good role unless patient is having visual deterioration. And glucocorticoids are strictly contraindicated. You can give in a case of inflammatory disease like SLE or Behçet disease that are causing the cortical venous thrombosis. And the shunt replacement is also not recommended. Okay, these are all the recent guidelines. You can use therapeutic lumbar puncture and acetazolamide in a case of cortical vein thrombosis, raised ICC, which is leading to the visual deterioration, and glucocorticosteroids only in a case of inflammatory disorders that are causing the cortical vein thrombosis. And there is no role of shunt replacement. Okay, shunt placement. Next slide. Any doubt in this slide?
Sir, visual deterioration was a criteria to give acetazolamide. No, sir. What if the patient is like in altered sensorium, sir? Is there any alternative way?
Alternate way you can look for like menace reflex. You can do like by throwing the light on the patient face. If patient vision is intact, or visual pathway is intact, sometimes patient may follow the light. One of the clue. But after starting your heparin therapy or anti-edema therapy, patient will improve. And these are the acute CVT setting. Most of the time, chronic venous thrombosis that is leading to the raised ICT. That time patient will be conscious, alert, and patient will having only visual problem. You know the idiopathic intracranial hypertension, IIH you heard, no? Pseudotumor cerebral. Anybody? Hello? Hello?
Yes, sir. Yes, sir.
Pseudotumor cerebral you heard, no? IIH
Yes,
pseudotumor cerebral. In that, what happens in a chronic CVT patient? Due to the occlusion of the venous sinuses, patient will have papilledema and vision loss and headache, but sensorium would be normal. So in that setting, acetazolamide and diuretics and therapeutic lumbar punctures carries very good prognosis. Okay, in an acute setting, it is difficult because of poor disease to assess the vision. That would be very difficult. So chronic CVT setting, it would be helpful. In an acute setting, it is difficult to assess the vision. Any other questions? Okay, next slide. Most of CVT have good prognosis. By the end of 3 months, patient around 80% of the patient will have recanalization. At the end of 1 year, around 85% of the patient will have proper recanalization. And good prognosis will be for deep cerebral veins and cavernous sinuses, and lowest rate for the lateral and sigmoid sinuses recanalization. Next slide. And some will consider some special scenarios. Most often you see the cortical venous thrombosis in the pregnancy. If a pregnant woman diagnosed a cortical vein thrombosis, that time you cannot give the anticoagulant drug, warfarin or dual direct oral anticoagulant because of the teratogenicity. You need to give the heparin even 8 weeks after the postpartum period also. And if patient is having the recurrent CVT, like 2 or more than episode of 2 CVT in a pregnancy, you need to give prophylactic low molecular heparin in the future pregnancies. Okay. Any doubt in this slide? This is very important slide. Most of them will get the reference from the OBC. Diagnosed a headache for the headache and papilledema. You diagnose the cortical vein thrombosis. That time don't write warfarin or any teratogenic drug. You need to advise them for heparin or low molecular heparin throughout the year, even after postpartum, 8 weeks of postpartum. Because of these drugs sometimes secrete in the breast milk, that will also causes the bleeding diathesis in the kid. So most of, as I told earlier, postpartum CVT don't think only dehydration is the cause. So if patient is affordable, kindly work up for the other causes. 50% of the patient will have other causes also. So if you miss the other causes, chances of reoccurrence of CVT will be there, and duration of the anticoagulation will be again unplanned if you don't identify the causes. Any doubt in this slide?
No, sir.
Okay, next slide. And one more entity is there. This is vaccine-induced immune thrombotic thrombocytopenia. Here, patient will present as cortical vein thrombosis only. But after you taking the history, you come to know that 30 days ago, patient had vaccination and patient had thrombocytopenia less than 1.5 lakh. In this setting, if you give heparin, again, it will lead to the hemorrhages, and heparin-induced thrombocytopenia will lead to the bleeding risk and patient will die. So in this setting, you cannot give heparin. You can use the indirect heparin derivative like danapirid or fendonfernex that will not cause usually heparin-induced thrombocytopenia, and IV immunoglobulin will be the best choice for this kind of patient. So most of the time during the post-COVID time or after vaccination, patient comes with a history of headache, focal deficit, you diagnose the CVT, and routine evaluation you found to have thrombocytopenia. So in that setting, don't give low molecular weight heparin. Rather, you can give indirect hypertension factors inhibitors like danapirid or fendonfernex. Then, along with that, you have to give the IV immunoglobulin to treat the vaccine-induced immune reactions. So if you don't identify these cases, patient will land up in the hemorrhagic conversion, and if you don't treat properly, it will lead to the mortality rate at around 22%. Okay. Any doubt in this slide? Have you seen any like vaccine-induced cortical vein thrombosis?
No, sir.
No, I think seniors might have seen, I think. Okay. Because post-vaccination, many cases, n number of cases we had seen. So they were having thrombocytopenia also, okay, and high D dimer level, and some extracranial venous thrombosis were also there. Okay, be alert. So post-vaccine induced thrombosis, because the management is very different. You have to give IV immunoglobulin and indirect factor 10A inhibitors. Okay, next slide. This is the slide. A patient comes with a complaints of cortical vein thrombosis and past history of COVID vaccination. Around 1 month, this is in the previous year, 42 days, up to the 42 days. You did the routine investigation. Patient found to have thrombocytopenia, and you did the anti-platelet factor 4. This is for heparin-induced thrombocytopenia. You found to have heparin-induced thrombocytopenia is also there, and along with thrombosis also there. In that setting, you need to suspect the vaccine-induced immune thrombotic thrombocytopenia. So after diagnosis this, you need to give IV immunoglobulin and other heparin derivatives like danapirid and fendonfernex. Okay. Any doubts? Okay. Next slide. Okay. Last one is like any role of thrombolysis or thrombectomy in cortical vein thrombosis. There are no trials yet proved this benefit of thrombolysis or thrombectomy. Some of the trials they say deoxymethohemoglobin rich thrombus will have good prognosis after mechanical thrombectomy, but very less number of trials are going. As of now, if anybody asks, just you tell no randomized trial completed an IV thrombolysis or mechanical thrombectomy in a setting of cortical vein thrombosis. Okay. Next. Okay. Any doubts?
Sir.
Hmm.
Sir, sometimes in our hospital we get patients. These are history will be usually young-aged males, sir. Post alcohol binge for 3 to 4 days, they present with loss of consciousness or seizure, sir. On imaging, we find cortical vein thrombosis, and we start this anticoagulation, but they don't usually improve within 5 days, sir. Around after 1 week or 10 days, they usually succumb to some other cause, sir. When should we suspect that Like more than, is there any role of giving anything other than heparin also, sir? Like when should we be alerted to the like danger signs, sir?
I told you that cortical venous thrombosis risk score I told you prior. You calculate the risk. If score is more than 3, patient definitely
sir.
will land up in the complication. So that time you should be alert and you keep on touch. You should be discussing with the neurosurgeon. So in that scenario, decompressive hemicraniectomy would be the better choice. If patient deteriorating even after your treatment, if the risk score is more, you should be alert. Okay, raised ICT features are there, midline shift is there, your pupils are also involved, and PCA territory hypodensity is also there. These are the very red flags, and in that setting, surgery will have good results. Okay.
We calculate the score at time of admission, sir, when we start the first anticoagulant. After that, we should recheck, sir.
Yeah. You
At what
should
time interval, sir? What interval, sir?
I don't know actually exact duration of timetable. You should monitor GCS because after this CVT hemorrhagic, if hemorrhagic infarcts are not there, the chances of raised ICT will be less. If hemorrhagic infarct is there, patient will have deterioration predominantly 72 hours. They say 2 to 3 days of hemorrhagic conversion. Patient will deteriorate. So if you treat with a good anti-edema measures, you can prevent it from the midline shift or any mass effect. Ideally, 3 days or 72 hours basis.
Thank you, sir.
First 3 days, you should be alert. CVT with hemorrhagic conversion, first 3 days, you should be alert. You should, I think, better to monitor in the ICU only. Every hourly GCS, you need to monitor. You need to check the pupil. You need to check the planters of opposite leg. And you need to see for any deterioration or any repeat imaging. If patient GCS is deteriorate, you need to recheck. You need to send the patient for CT scan, and you need to see for the PCA territory hypodensities for the indirect signs of herniations. And in alcoholic patient, again, if patient not improving means you need to see for other causes also. Might be alcohol withdrawal, alcohol tremens, or patient will be having nutritional like associated wernicke's encephalopathies. All those things to be addressed. In alcoholic patient, not only CVT, other these factors also you should see. Wernicke's encephalopathy, Korsakoff psychosis, hyperhomocystinemia will also be there, and withdrawal symptoms will also be there. All these things to be addressed in a alcoholic patient. And doubts?
For how many months you have to continue for anti-seizure medication?
Usually you can classify as seizure as early stroke and late stroke seizures. Early strokes would be less than 2 weeks. A patient, you diagnosed a cortical vein thrombosis, and patient started having the seizures within like 2 weeks. These are called early stroke seizures. If patient started having seizures after 2 weeks of your vascular event, that is called late stroke seizures. Usually late stroke seizures may land up in the epilepsy. They may need anti-epileptic for lifelong time. If a seizure patient having seizure within 2 weeks, that time early seizures will have good prognosis. You can give up to the 4 to 8 weeks. Around they tell 2 to 3 months you give, and you can stop the anti-epileptic. Early seizures, you can stop early. Late seizures, you need to see. Most of the patient will land up in epilepsy. And prophylactically, don't give anti-epileptic. If patient thrown the seizure only, you can give. Or any doubts that?
If it is chronic, after 6 months,
Answer.
6 months to 1 year of anticoagulation, Then anything still if it is persisting of this one means how to continue anticoagulation or any this one mechanical thrombectomy or anything.
Sir, mechanical thrombectomy, like they're saying, most of the trials they have not shown any benefit from the mechanical thrombectomy. By doing like in a cortical vein thrombosis, a patient is having deoxymethemoglobin rich thrombi will have good prognosis for mechanical thrombectomy. Sir, that cannot be done in our center, sir. Usually, ideally, tertiary or good stroke intervention units they will do, sir. Usually, no role of mechanical thrombectomy routinely. And no need of doing the repeat venogram studies. If patient clinically improving, not having any papilledema, no deficit, headache resolved, that indirectly indicates thrombosis is clearing. Duration, as I told earlier, depending on the risk factors or depending on the etiological agent. If you don't get any cause, only first episode, give for 6 months or 6 to 12 months, they say, then you leave. If recurrent episode, if you don't get the cause also, you have to give lifelong. Recurrent episodes with pro-thrombotic status, again you have to give lifelong.
Thank you.
Okay, sir.
Thank you, sir.
Thank you. Okay, bye.
Thank you.
Abhishek.
Sir, हाँ sir. हाँ sir.
Why I told you to see today is
Platelets.
anemia.
हाँ sir, बताइए. हाँ sir.
Because of thrombocytosis. That's
Okay,
why I
sir.
told to read for him.
Okay, sir.
So in that
Okay,
way,
sir.
it causes this one. I had one
Isolated
patient.
thrombocytosis. हाँ sir.
I had one patient. She was she had underwent to PTCA. Okay, 8 months back.
Okay, sir.
Okay, and she fell down. Okay, and she had a fracture. Okay.
Okay, sir.
She was on dual antiplatelets, so we stopped her on antiplatelets and started on heparin. And with the risk of this one, we took her with risk of crescent thrombosis. We took her for OT after 5 days of stopping, but we were giving heparin. Okay. Post OT, we were delayed to start heparin. She within of 30 hours she developed a thrombosis. Okay.
Okay, sir.
Pulmonary embolism. Okay, we detected
Okay, sir.
and we thrombolized it also. But she had one of her, she had anemia. Because of iron deficiency, she has thrombocytosis. Okay, and we treated her anemia, iron, everything. In spite of that, she was getting thrombocytosis. So then, when we got done her JAK2 mutation, everything, she was positive. So scenario
Okay, sir.
is thrombocytosis, but when you correct the iron deficiency anemia also, still there is a persisting think of other disease, hyperproliferative disorders.
Yes, sir.
This one I learned from that patient because of I know anemia iron deficiency anemia causes thrombocytosis. But in spite of correcting her anemia, still there was thrombocytosis. It was like lakhs together, 7 lakhs, 7 lakhs, it was like that.
Okay, sir.
Okay. This one you keep it. That's why I told you to read and calculate.
Yes, sir.
Okay, thank you.
Thank you, sir.